From now on, I am going to show you some of the important messages related to diabetic feet. Diabetics should treat their feet like they do to their face. All of us wash our face at least 3 or 4 times in a day. Look at the mirror. Do lots of makeup. Present our face in the most presentable form. But we forget to give the same care to our feet. This is even more essential for a diabetic patient. He must wash his feet every day. Look at the feet at least once a day. If he is not able to look at the undersurface of the feet directly by himself, either his companion or family member can help him to examine his feet, or he can use a mirror to see the undersurface of the foot. This is what is meant by they must treat their feet like they do to their face. The foot is as important as the face. It is foolish to consider that diabetic foot problems occur all of a sudden like a bolt from the blue. Till yesterday the patient's foot is excellent. Today morning he gets up, there is a need for amputation. It never happens. Till 2 days ago he is walking with sensate foot, pain and pinprick are appreciated well, and from today he is not able to feel any pain and he has ulceration on the foot. Never happens. These give enough time, a long row, a long time. When you contact the patients of diabetes several times, you are given enough time and opportunity to look at the various manifestations that can predispose the foot to greater problems. So, diabetic foot problems never occur all of a sudden. They give enough time. Only thing is we ignore the initial signals. We ignore the warning symptoms. We ignore the pressure points. We ignore the deformities. We will not test the feet for sensation. We will ignore ulcerations of small nature. We will say they are trivial ulcers. The small cut, a small ulceration, a trivial ulceration. Remember, there is nothing called a trivial lesion as far as diabetic foot is concerned. We have seen several pictures of diabetic feet, starting from the pressure points, the callus, the deformities, the ulcerations, the deep excavating ulcers, the loss of digits, the Charcot feet, the dry gangrene, the wet gangrene, and the amputations. But it will be a tragedy if we restrict the term diabetic foot to only to the advanced stages of disease. Diabetic foot means not a limb which has lost vascularity, not a limb which is ready for amputation. Diabetic foot means insensate feet, sensory neuropathy, early motor neuropathy, the deformities of diabetic foot, the pressure points of diabetic foot. The pre-ulcer stages of diabetic foot are more important for us to be picked up. Once the ulcer develops, the infection progresses and the vascularity is compromised, there is nothing that you and I can do. It is important for us to pick up these patients quite early, so much so the term diabetic foot includes all those early changes that occur over a period of time. The aim of any diabetic foot care should be to preserve the limb, not to amputate the limb. Amputation is the last resort. If nothing can be done, if the foot cannot be salvaged, then of course to save the patient you do an amputation. To save the patient from spreading gangrene and infection, you may need to do an amputation. But that is not the thing that we have to keep in mind. We have to see a good diabetic foot care means to preserve the limb at any cost and apply all that we can do to preserve the limb. This is what is called the high risk diabetic foot concept. Understand which feet are at high risk and identify those high risk feet and see that they will not go into a stage of irreversible damage. My dear friends, volumes and volumes are written on diabetic foot. In fact, if you look at the literature on diabetes, no area of diabetes is as much flooded with literature as the diabetic foot and its problems. Probably next comes only the oral hypoglycemic agents and the insulin. The area of diabetic foot is so much served by wonderful research papers. So, there is no dearth of knowledge. The problem is there is a yawning gap between what is known about the diabetic foot and what is really done to the feet of diabetic patients. We know very well what are the earlier signs of diabetic foot which can progress on to ulceration and further on to deeper infections and compromised vascularity and end up in amputation. This knowledge is not at all difficult to acquire. But the problem here, it is not the knowledge aspect that is lacking. It is the problem of attitude and practice. We are, as physicians, we do not possess the right attitude and practice to prevent diabetic foot amputations and diabetic foot complications. Though we have the knowledge, we often ignore our responsibility of helping the patient and identifying him or her in the early stages of diabetic foot. So, I urge to all of you, my dear friends, to keep a positive attitude in preventing foot problems and apply the knowledge of diabetic foot problems into your practice and see that your patients are benefited and in the community is benefited at large. How do I assess whether a diabetic foot care program in a particular country is working well or not? One important yardstick is to measure the non-traumatic amputation rate. Tell me the non-traumatic amputation rate in your country. I will tell you what is the quality of diabetic foot care in your country. This is the way it is put forth in Diabetic Care 2003. I said non-traumatic amputations because diabetes mellitus is the commonest cause of non-traumatic amputations. If you leave traumatic amputations aside, from among the remaining amputations, 80 to 90% of those non-traumatic amputations are due to diabetes mellitus. If the non-traumatic amputation rate is very high, the foot care program and the physician awareness, physician motivation, physician attitude and physician practices are very poor. If the physicians are identifying at a very early stage and they are able to prevent the diabetic foot complications, the amputation rates will sure be on the lower side in any country. I told you that the amputations secondary to diabetes are very, very common. Diabetes ranks as the highest cause of non-traumatic amputations. In the world over, every 30 seconds, one amputation of diabetic foot is being done. By the time we have completed this presentation in 1 hour, there would be 60 amputations already done. Frightening, isn't it? If you look at the Lancet 2005, in this issue, this is what is stated. The enormity of global burden of diabetic foot disease this much neglected but potentially devastating complication of a disease that is reaching epidemic proportions. Already we are in the epidemic of diabetes. Remember, someone somewhere on this globe loses a leg because of diabetes every 30 seconds of every day. How else to emphasize, my dear physicians? Let us put our heart and soul to prevent this tragedy of diabetic foot amputations and their so much high, enormous rate of occurrence. The best way is to identify the foot problems at a very early stage and see that the feet are saved. Having already said that the term diabetic foot or diabetic foot problems are not restricted only to the end stage or burnt out cases, but they include the very early deformities, the calluses, the insensate foot, the ulcerations also. We need a definition, a working definition to understand what is a diabetic foot. For that reason, in the year 2003, an international consensus on diagnosing and treating the infected diabetic foot has been formed, and they have defined diabetic foot as any infection involving the foot in a person with diabetes originating in a chronic or acute injury to the soft tissues of the foot with evidence of pre-existing neuropathy and or ischemia. Further, we will see the definition offered by WHO in the next slide. The WHO definition of diabetic foot, whenever I use DF, it means diabetic foot. DFU means diabetic foot ulcer. The foot of a diabetic patient that has the potential risk of pathological consequences, including infection, ulceration, and or destruction of deep tissues with associated neurological abnormalities like motor neuropathy, sensory neuropathy, and secondary effects of neuropathy, various degrees of peripheral vascular disease, and or metabolic complications of diabetes in the lower limb. Applying this broad definition, diabetic foot encompasses very early stages of decreased sensation of the feet, the early diabetic sensory neuropathy, the diabetic motor neuropathy, the associated foot changes, the pressure points that they develop, and the calluses. The calluses and the pressure points give way to ulcerations. Ulcerations end up in infections. Infections in deep-seated infections and osteomyelitis. Compromission of vascularity due to diabetic peripheral arterial disease, resultant deep ischemic changes of the feet, and all these ending up in devastating complication of diabetic foot amputation. So this is a whole spectrum of manifestations of diabetic foot.